First of all, welcome. Yesterday first round session of DRNB surgical onco is over, and new set of students have come. And this time it's a record. Total around 280 seats, both MCH and DRNB surgical onco together is available, and more than 200 students have taken surgical onco yesterday. So welcome new students. Welcome to your respective institution, and I wish a very great career in surgical oncology training and life ahead. Today we have a fantastic talk. This is a rare disease but very common in Tamil Nadu. So who else you can have? My dear friend, most great academician who probably has very high number of publication in this field, who is an excellent surgeon, academician, researcher, and great teacher also. Professor Dr. Anand is a professor and he heads the division of Uro-Onco, and he is very multifaceted. We'll love to hear from him, and most of the work is his original work. Penile cancer is a rare cancer but very common in Tamil Nadu. Its management needs to be understood very well. What are the guidelines for primary management? Groin, sentinel node, lymph nodes, block dissection, and balance the radiation, sentinel node, neoadjuvant chemo, now the role of immuno. So thank you very much, Anand, for accepting at a short notice, and great thanks from behalf of NBEMS and myself and the students, and over to you.
Hi, thanks. Without much further ado, dear students, so carcinoma penis, like Dr. Somashekar said, is it looks to be a very easy disease. We've been managing it from when we were MBBS students, and you've seen a lot of it in our MS as well. But it's really quite a misunderstood disease, and palpable nodes, non-palpable nodes, what to do, what not to do, what to do for the primary. It's really a very vast topic. In my own head, when I think about management of penile cancer, I really think of penile cancer management under 4 different headings. On what is the management of the primary, what is the management of the groin or the nodes, what do we do for inoperable or borderline operable tumors, and what is it that we do for the metastatic penile cancer. To cover everything comprehensively in 1 hour time might be slightly difficult. So with the permission of Dr. Somashekar, I kind of decided to focus on only one thing, and if we can get this right in penile cancer, I think most of our job will probably be done very well. So this entire talk today, I'll be focusing on how do we manage groin nodes in carcinoma penis, which I think is where the crux of penile cancer management really lies. And this talk will be structured in under 3 different heads. First, there is this management of groin nodes in penile cancer. How do we do it? Followed by a short 3-minute video on dynamic sentinel lymph node biopsy in penis. How is it that it is actually done? And once we know how to manage the groin and how to really do the surgery by way of a video, we will run through a short case capsule. This case capsule I had prepared for something else, but it will be very pertinent here because knowing that case capsule, it really encompasses the entire management of penile cancer from the primary to the groin to everything else. So we'll quickly run through that. So now coming to management of the groin nodes in penile cancer. Management, like I said, the management of in penile cancer is broadly divided into management of the primary and management of the nodes. Again, management of the nodes can be based on whether there's a lot of confusion. What is a palpable node? What's a non-palpable node? What's a positive? It can be either palpable or non-palpable. Based on histology, it can be either positive for metastasis or negative for metastasis. So how do we go around, solving this conundrum? So we do know that nodal involvement is the most important prognostic factor for survival. Unlike most other tumors, lymph node involvement in penile cancer does not always imply that systemic disease is present. And lymphadenectomy in patients in whom the groin nodes are positive alone can be curative in a substantial number of patients. So the tumor biology is such that it has prolonged loco-regional phase before it really becomes systemic. And we have to take advantage of this window of opportunity in the natural history of carcinoma penis, because this is very important for treatment. So like I said, This has a prolonged locoregional flow before it becomes systemic. And penile cancer has one very important characteristic in the way that the lymph nodes are involved. We know that the groin nodes are divided into two, the superficial femoral and the deep femoral, and then the iliac, or the superficial inguinal, the deep inguinal, and then the iliac. The pattern of flow is always stepwise. The superficial nodes will be involved always first. The superficial nodal involvement will then lead to deep nodes involvement. There is no scenario, unlike in a tongue cancer where you can have a skip metastasis to level 4. In penile cancer, there will be no skip metastasis to the deep inguinal nodes. The deep inguinal nodes will never be involved in the absence of involvement of the superficial inguinal nodes. The same stepwise progression also goes to the iliac nodes. The iliac nodes will never be involved if the deep inguinal nodes are not involved. So this is very, very important. And why is this important? This is important to stage the groin, in the sense that if you have to stage a CN0 groin, you can remove either one node, which is the DSLNB, but because DSLNB is little difficult to perform standardization and so on and so forth, all that you need to do is remove the superficial group of inguinal nodes and send it for biopsy, either a frozen section or permanent pathology, and see if the nodes are involved. If the nodes are not involved, there is really no need to go ahead and do a deep inguinal dissection, which can limit your morbidity. So this has important implications, therapeutic implications, in view of how do we stage the groin. So if you can get this right, your understanding in penile cancer has really moved a point. And how do we evaluate the groin in penile cancer? Evaluation of the groin can be in multiple ways. It can be either clinical or surgical. So clinical includes both clinical and imaging. You can examine the groin, but like we always know, the ultrasound is better than the tips of your fingers. So you can do an ultrasound of the groin and guided FNACs. You can also do CT scans, MRI, and rarely PET CT scans for evaluation of groins. Although PET CT scan is not the standard of care, a high resolution ultrasound with guided FNACs will tell you a positive node in most instances. And suppose you come across that it's a CN0 or CN plus groin, it is surgically evaluated by either a dynamic sentinel lymph node biopsy or nodal pick, which is really not done. The sentinel node biopsy of cabanas, again, which should not be done because there's a very high rate of false negative. The DSLNB in our hands has a false negative rate of 3%. If you do not have facilities for DSLNB, you can do bilateral superficial inguinal block dissection just to stage the groin. And if it is positive, you can do the modified bilateral inguinal block dissection. I am not purposely talking about the video inguinal lymphadenectomy here, more about that in a bit. In clinical examination, almost 50% of patients with clinically node positive with palpable nodes harbor metastasis. And there is this thing about, in palpable nodes. So whether in India, as per published data from our own institute and from other high volume centers also, most people in India are barefoot walkers. You might be wearing shoes outside your house, but inside the house, most people are barefoot walkers, where the instance of a palpable inguinal node, which is clinically negative, even in normal people, is up to 50%. So the Western concept of palpable versus non-palpable node really does not apply to India. What is more important is whether the palpable or the non-palpable node is it pathological positive or not. That is what is the crux of the matter. Patients with palpable nodes in high-risk penile cancer, as per the EAU classification, even after a course of antibiotic therapy, is as high as 70 to 90%. Whether palpable or non-palpable groin, if non-palpable, you need to do an ultrasound and guided FNACs to see whether it is pathologically positive or not. Ideally, should be done from multiple nodes and do it from suspicious nodes. Guided FNACs can sometimes be cumbersome and has a high false negative rate and has a sensitivity of only 37%. So what does this mean? This means that if you have the value is only to stage the groin is only for a positive node. You've done an ultrasound and a guided FNAC, and if you get a positive report, that has a lot of significance. But if you have an ultrasound and a guided FNAC and that shows that the node is negative, it does not rule out a positive node. You still have to go and stage the groin. So that is what this slide really means. CT scans and MRIs, these are really sensitive investigations for evaluating pelvic nodes. They are indicated either in multiple inguinal positive nodes or a positive pathological node or in patients with large inguinal nodes. It can be useful in planning neoadjuvant therapy and also in assessment of response. PET CT scan, like I said, as per the EAU guidelines, PET CT scan is evaluated in is recommended in evaluation of patients with positive inguinal nodes. It has a positive predictive value of 94% and a negative predictive value of 96%. May also be useful in detecting unsuspected site of metastasis, especially if there are ambivalent findings. So coming to the sentinel lymph node biopsy, this was procedure was originally described for penile cancer by Cabanas. He said that the medialmost node, which is medial to the vessel, should be the site of the sentinel node. He aimed at removal of the first affected node, which was usually located supramedial to the junction of the saphenous vein to the femoral vein. But this kind of very quickly went out of vogue because it had a very high false negative rate. Sentinel node was then, of course, picked up by people treating other cancers, notably melanoma and breast cancer, when it where it became really big. The sentinel node biopsy had a kind of resurgence from the Netherlands Cancer Institute, where they used both blue dye and radiocolloids, and by the Sentinel paper by Groin et al., which kind of standardized and put sentinel node DSLNB, dynamic sentinel lymph node biopsy, again square back in the management of penile cancer. We kind of adopted this very early in 2010-11, where so the DSLNB is done using both blue dye and radiocolloids. It involves injection of the radiocolloid, static images, and localization of nodes in the nuclear medicine suit. And the patient is then shifted to the operating theater, where blue dye injection intradermal is done with identification of blue color and nodes through a handheld Doppler. Why is we keep going on and on about staging the groin nodes. Why is it really important? Because we know that the most important prognostic factor in survival for penile cancer is nodal metastasis, like I told in my first slide. The 5-year survival without pathological node positive is about 70 to 100%. With inguinal nodes that are involved but completely resected, overall is about 60%. With minimal nodes involved is about 77%. With multiple nodes involved, it drops to about 25%. With unresectable nodes, which remain unresectable after giving a course of neoadjuvant chemotherapy, is 0%. So nodal metastasis identification early and treating it early leads to improvement in survival. The other factors, so what are the factors that really, the factors in the primary that influence whether nodes will be involved or not? They include the grade of the tumor, what is the histology of the tumor, whether the corporal involvement is there or not, urethral involvement, although urethral involvement is now taken away from the AJCC, what is the lymphovascular embolization, DNA ploidy, and P53 and HPV mutation status. Here we've looked at all of these studies. This looks like a very busy slide, but on multivariate analysis, as you can see, most of these factors have been found in various studies to influence nodal positivity. And we know that urethral involvement is taken away, but corporal invasion is very, very, very important. And once the corpora is involved, invariably nodal positivity does occur. If it's a T1 lesion and low grade, grade 1 or grade 2, does not rule out metastasis. In our own experience, as per the EAU low risk classification, the risk of nodal involvement is up to 6 to 7% in our own DSLNB series, which means that they cannot just be ignored away. in once the nodes are involved, does that how does that influence survival? So then multiple factors in the node itself influence survival, which can be either single or multiple node involvement, size of the node more than or equal to 4 or more than 4, whether it's unilateral or bilateral nodes, whether extracapsular spread is there or not, perineural invasion is there or not, and whether pelvic nodes are positive or not. So all these factors within a node positive influence survival. Again, as you can see, as the number of nodes increases, as the pelvic node positivity increases, survival drops. So what is really the problem in staging inguinal nodes, in doing, you can say that, all these factors influence survival, and we know that nodal positivity is an important prognostic factor. So why don't we go and do ileoinguinal block dissections for all, or do superficial inguinal dissections for all? Why do we need EAU risk stratification system where you avoid staging the groin for a few subset of patients? It is morbidity, morbidity, morbidity. All of us who've been treating inguinal block dissections, who've been doing that even for staging inguinal block dissections by DSLNB or sentinel nodes by superficial block dissections, do know that the morbidity is not small. For those small subset of patients who have lymphedema, chronic lymphedema, we even had patients in the past who had lymphangiosarcomas. We've heard it only in breast cancer. We have it in penile cancer also. There have been histories and there have been patients who needed to have amputations done for the lower limb for gross lymphedema, scrotal edema, so on and so forth. So you have to really pick and choose which patients to offer staging. DSLNB has simplified it very much. More about that later. So complications, like I said, can be large: lymphedema, wound infection, seroma formation. I think I don't need to go too much into this. We are all aware of this. So the aim, so this is the background of nodal involvement. But in managing nodal involvement, the aim is to reduce morbidity and mortality and to improve survival. It is to detect metastasis at an early stage before clinical detection and treat it, to do a lesser procedure, reducing morbidity and improve survival, but at the same time having accuracy of detection. So if we have to do all this, we need to really understand the natural history of the disease, which I have gone through a little bit earlier, and we should optimally use the lead time to our benefit. Again, this is the natural history is such that there is a long preclinical phase. Again, there is a long clinical phase when it is early nodal involvement, clinically detectable nodes. Where there is clinical stage, you can still do therapeutic nodal involvement. After this only it becomes incurable or metastasizes and finally leads to death. So you should take advantage of the natural history of disease. So the management of an N plus groin is fairly simple. You do the ileoinguinal block dissection with or without neoadjuvant chemotherapy or adjuvant chemotherapy, more about that later. But how do you manage a CN0 groin? Before we say CN0 groin, what is a CN0 groin? A CN0 groin is not just a palpable node which you cannot feel in your hand. A CN0 means it is not detectable on clinical examination. You have done an ultrasound, a high frequency ultrasound, and you have done guided FNACs, and they are still negative. So the options of CN0 groin are surveillance for the EAU low risk. For the intermediate and high risk, you can do bilateral superficial inguinal lymphadenectomy. You can do sentinel lymph node biopsies, which is not done these days. You can do a dynamic sentinel node biopsy. You can do veil. Although I do have a small problem with veil, because veil usually, or robotic veil usually, involves removal of both superficial and deep inguinal nodes. And if the deep inguinal nodes, if it turns out to be a CN0 groin, you've removed the deep inguinal nodes when there would have been no need to remove it, leading to more treatment, over treatment, and over lymphedema. So we are big proponents of DSLNB. What to choose? We do know that early lymphadenectomy has now become the standard of care in high risk N0 groin because of risk stratification. We do know that from the earliest papers by Ravi et al., treating nodes which are clinically negative but which may be positive earlier compared to later when they become manifest leads to detrimental improvement in survival. And there are multiple modifications, the MILDs and the SILDs, which reduce with reduced morbidity. You can still do the same procedure. The EUA risk stratification, like I already said, is low risk, intermediate risk, or high risk. Again, a small point of technique here, that EUA recommends that in the EUA low risk, you do not need to go and do the inguinal staging inguinal lymphadenectomy. Now, the reason that EUA recommends that you should not do the bilateral staging inguinal lymphadenectomies for groin is not that you will not pick it up, but it is the balance between the morbidity and the risk of pick. In the low risk, the risk of metastasis as per EUA is really less than 3 to 4%. So you will be subjecting 100% of the patients to the morbidity of a staging inguinal lymphadenectomy when only 2 to 3 patients will be benefited. So the risk benefit ratio does not favor a staging inguinal lymphadenectomy, but we do not believe this. What we do is we go ahead and do DSLNB for all of these patients, because DSLNB in our hands, the risk, or in any hands with experienced centers, the risk of complications in DSLNB is close to 0%. So it can be offered to all patients across all stages. Like I said, again, the only series by Ravi et al., which was published way back in the early 80s, it has shown, and again this is an important slide, please read through this. It has shown that early lymphadenectomy versus surveillance did not show a difference in survival. But in that study, only 8% in the survival arms recurred. But when it was compared to patients who had positive nodes, patients in the surveillance arm had much inferior survival compared to patients who had early inguinal lymphadenectomy. So what are the techniques in which you can reduce the morbidity of the bilateral staging inguinal lymphadenectomies? It is better pre-op antibiotic therapy, better post-op care, give smaller incisions, probably thicker flaps, always preserve the saphenous vein, limited dissections, and use of flaps to cover the vessels. So the DSLNB, the sentinel node and its extension, the false negative rates was more than 10%. In the Curtis Petaway series from MD Anderson, even after extended sentinel nodes, the false negative rate was really high. So DSLNB really came about by Groin et al., where the false negative rates was grossly reduced. The Horenblas series paper, which was published in 2009 in JCO, they had a total of about 325 patients. Sentinel node identification rate was 97%. In 79 groins, a sentinel node was positive. Anyway, out of all of these, the combined false negative rate for the first time, they were able to reduce it from to less than 10%. They brought it down to 7% with a complication rate of 4.7%, which has now further reduced. Video inguinal lymphadenectomy, like I said earlier, was introduced by Bischoff et al. It uses 3 trocars. It again has reduced the morbidity of the inguinal lymphadenectomy. But there are 2 inherent problems here. One, long-term oncological outcomes are yet awaited. And like I said, if you might be all right to do it for an N+ patient, but for an N0 patient, because you end up removing both the superficial and deep nodes, if the final pathology is N0, it might be over treatment for those group of patients. What do you do about clinically palpable node? In the initial FNAC you have to do, if it is positive, then you go ahead and do a therapeutic inguinal lymphadenectomy. Books say that you should, if it's negative, you should wait for 4 to 6 weeks of antibiotic therapy. If it is still positive, then you go ahead and do bilateral inguinal lymph node dissections, because a lot of them will harbor positive nodes. We usually do not do all these things. What we do in our hospital setting is that when the patient comes to OPD on the first day with palpable inguinal nodes or an ulcerated tumor in the groin, you start them on antibiotics, and then you stage the groin and the primary in the same sitting, by which time the patient already have got 1 or 2 weeks of antibiotics, which will be enough to clear most of these away. The problem with doing all of this, like I said, is morbidity, And I think we've already spoken about all of these things. So we published our first paper on DSLNB way back in 2015-16, where what we did was we did DSLNB and then we went ahead and did a superficial groin dissection for all of them to standardize our procedure. 20 groins, 20 patients, 40 groins from Feb 2010 to 12. All of them were clinically node negative, non-metastatic, and DSLNB was done at the same time as primary. So, like I said here, this is an important slide. Our SLNB positive were 9. Our false negative was only 1, which was the first patient in the study. So the identification rate was 97.5%. The node positive rate was 25. The false negative rate was 10%, was actually only 1 out of the subset. The sensitivity, specificity, and accuracy were 90, 100, and 97.5%. The sentinel node as the only positive node was seen in 7 groins. Of these, 4 had a single node positive and 3 had more than 1 node positive. The total number of sentinel nodes identified were 2.3 nodes. No regional recurrences have been noted after superficial groin dissection. The journey since, we've done N is equal to 174 patients, 301 groins. The false negative rate was 99, identification rate was 99%. The false negative rate is now 4.5%. Sorry for that typo. So, if you have unilateral node positive, if you have FNAC on one side, do you need to go and address both sides? We know from Dr. Ravi's paper previously that if one side node is positive, the opposite side has to be addressed. You have to stage the opposite side. How do you stage the opposite side is really up to you. If you have facilities for DSLNB, you can stage the opposite side by DSLNB, else by a superficial block dissection. The SLNB study by Horenblas showed that bilateral sentinel nodes can be there in up to 80% patients. Involvement of the contralateral node in patients with positive nodes on one side is up to 50%, even if the contralateral node is CN0. But patients, so what do you do if you have treated one side, opposite side is negative, ipsilateral side, on one side you've done ileoinguinal block dissection, and then the patient recurs. So patients who develop metachronous metastasis, that is even 1 year of the after treatment of the primary, can be considered for unilateral dissection alone. What we usually do is that if the patient recurs, it's a CN0 groin, you staged it with DSLNB, and suppose the patient has a recurrence in the ipsilateral groin, in one groin. If the recurrence is within 6 months after treatment of the primary, we go ahead and stage both the groins. But if the recurrence is 6 months after the treatment of the primary, then you might probably need to stage only one groin and not the opposite groin. Is pelvic node dissection mandatory? Pelvic node positivity we know has very poor survival. Most studies show survival of only about 10 to 15%. Ravi et al. Showed that if 1 to 3 nodes were positive, the survival was really, really poor. So pelvic node, as per textbooks, can be avoided if there is a single node positive in the inguinal region without extracapsular spread and the cloquet is negative. But in our country, this is a very difficult scenario to do, because what will happen if you really follow these guidelines is that you will need one treatment for the primary. Then you would have staged the groin by a DSLNB. If the DSLNB comes positive, then you go ahead and do a therapeutic inguinal lymphadenectomy, and then you have to wait for the biopsy to see whether multiple nodes are positive or not, extracapsular invasion is there or not. And then if any of these features are present, then you have to go and do a pelvic node, which might make it as the third procedure to do. So for ease of practicality, so you have to know what are the NCCN recommendations. These are the NCCN recommendations. But for practical purposes, most patients, if they are offered an inguinal block dissection, would invariably have a pelvic lymph node dissection done as well at the same time. What do we do for management of resectable N plus groins? If unilateral nodes are positive, they should be offered ipsilateral ileoinguinal block dissection, and a contralateral superficial block dissection, frozen section, and proceed to IIBD if positive. The alternate to the SIBD is the DSLNB, like I already said. If bilateral nodes are positive, then you should go for bilateral inguinal block dissection. Again, a small matter here that the incisions for the superficial block dissection staging lymphadenectomies are slightly larger. So it is better to send these nodes for frozen section so that you can complete the inguinal dissection in the same sitting. If you do not send it for frozen section, then the report will come in about a week's time, by which time the flaps for the inguinal block, for the superficial block dissection that you would have said would already be starting to heal. And if the node is positive, then you'd have to raise these flaps again to complete the inguinal lymphadenectomy, which would then lead to increased morbidity. So always attempt, if you are doing an SIBD, to send the nodes for FS and prevent the inguinal lymphadenectomy at the same time. Always remember here that a lot of patients undergo emasculations for total amputations. I mean, in today's day and age, emasculations are really never to be done unless the spermatic cords are involved. What about radiation for the groin? There is really no role for radiation in the primary treatment of resectable nodes. Adjuvant therapy can be considered if there are multiple positive node or extensive dermal lymphatics are infiltrated with extracapsular infiltration. However, always remember that adjuvant radiotherapy carries high risk of complications like lymphedema and pain. If you have done it after an adequate ileoinguinal block dissection, all the nodes are already removed, and whatever little lymphatics are there will probably get fried by giving radiation there. So you have to be very, very, very careful in the kind of patients that you choose for adjuvant radiation. Adjuvant chemotherapy can be considered if there are multiple nodes positive. What we usually do is, if there are 2 or more nodes positive, extracapsular infiltration, or any pelvic node positive, or bilateral nodes are positive, most patients will receive adjuvant chemotherapy. The standard of care as of today is the Taxol ifosfamide cisplatin chemotherapy. What do you do for unresectable or borderline resectable nodes? Again, a small matter of distinction. What do you do for borderline resectable nodes? Our protocol for borderline resectable nodes is to go ahead and resect. If it turns out to be inoperable, then you can give chemotherapy. The rationale why we go ahead and resect for borderline operable nodes for surgery is that in the best of hands, the TIP regimen that I said, when given in the neoadjuvant setting, the best response rates are of the order of 30 to 35%, which means to say that 60 to 65% of the patients will either have stable disease or progressive disease, which means to say that about 60 to 65% of patients who are operable today might not be operable after a course of neoadjuvant chemotherapy simply because of response rates. So if it's borderline operable, it might be better to resect if it is resectable and give adjuvant chemotherapy rather than giving neoadjuvant chemotherapy and risking it becoming inoperable. However, it is very different for if the nodes are primary unresectable. If it's an unresectable nodes or there are large pelvic nodes, you really have no other option. You could possibly try neoadjuvant chemotherapy followed by surgery if there's a good response. 3 years survival up to 30% can be achieved in a select group of patients. If non-responsive, patients can be considered for palliative RT or supportive care. What we've recently started doing is to consider a lot of these patients with inoperable nodes. As we know, femoral blowout is a real risk, or nobody wants to die out bleeding inside their home. So we've recently started considering a lot of these patients with inoperable inguinal nodes with risk of femoral blowout for vascular stenting. For stenting of the femoral vessels, you can put in a covered vascular stent, with usually a metal stent, so that even if the vessel gets eroded, it doesn't blow out, and you may need to cover both the artery and vein depending on imaging. So in conclusion, it is important to understand the natural history, early address the nodes. Newer techniques like DSLNB and Whale can be considered, although Whale with reservation. Optimal management of the nodes is needed to reduce morbidity, recurrence, and improve survival. Give neoadjuvant or adjuvant therapy as indicated. Thank you so much. Now, what we will do is we will quickly go on to a small video of DSLNB, and it's a 3-minute video with a voiceover. I mean, you can go through it and then we will see.
India,
We present our video on dynamic sentinel lymph node biopsy for CN0 carcinoma penis. DSLNB defines whether the inguinal lymph node is involved or not. If it is involved, the patients can then go on to have a radical inguinal lymphadenectomy, and it offers the potential for precise localization with low morbidity. This gentleman is a 73-year-old patient without any comorbid illness and evaluated outside for phimosis. The post-op histopathology was squamous cell carcinoma with a residual disease and with clinically N0 nodes. Is now planned for partial amputation with dynamic sentinel lymph node biopsy after discussion in the urology MDT. The procedure starts in the nuclear medicine department with topical spraying of lignocaine, 1 ml, 1 millicurie of technetium 99 metastable sulfur choroid is injected perilesionally 1 hour after injection. Lymphoscintigraphy is done to identify the number and location of the nodes. And the site of uptake of the node is marked on the skin, subsequent to which the patient is shifted to the operating theatre. The position of the patient is supine. 1 ml of methylene blue is taken in an insulin syringe and is injected perilesionally into the 4 quadrants of the penis, and waiting time is 5 minutes. The injection is given intradermal. The uptake in the primary is recorded on a chart. The incisions are marked for both the inguinal block dissection, the sentinel node incision, and in case the node is positive, what would be the future incision? Because the cavity which would be possibly be contaminated has to be removed. The incision is deepened and the node is localized. Any node that is blue or hot on the gamma camera is taken as the sentinel node of the CA penis. The incision is carried and deepened out and the nodes are dissected, taking care that there is minimal disruption to the lymphatics, to the fatty tissues of the groin. An attempt should be made to identify the lymphatics that drain. Yeah, so that was what was the small video on the DSLNB, and we'll quickly go through a case capsule in 5 minutes. So that leaves us about 10-15 minutes time for discussion. Let me see, where is the PowerPoint? Yeah. Sure, if I'm able to share the PowerPoint. Yeah. Yeah. Is my slide visible?
Yes, sir.
Yeah. So this was a 30-year-old gentleman who was a hypertensive, history of no history of multiple sexual partners, had a penile growth in 3 months duration. Clinical examination, the penis were really small in size, and although the tumor was only 3 centimeters over the glans penis and the meatus was made out, the penis was so small that it precluded a partial amputation for this patient. There were no palpable inguinal nodes. And we know that clinical examination in penile cancer always includes palpation of the perineal urethra as well. When we palpated that, there was a small nodule which was palpable in the perineum, 0.5 to 0.5 centimeters, which was firm. So the next investigations done were, the wedge biopsy from the penis was done, which was squamous cell carcinoma grade 2. The staging investigations, ultrasound and USC guided FNACs were done, which were negative. The ultrasound of the pelvis and retroperitoneum again were negative. So we did an MRI to see whether the nodule in the perineal urethra that we palpated, whether anything is there or not. Fortunately, on the MRI, nothing was there. So we just thought it's probably one of a corporal calcifications which we are palpating, and left it at that. The patient was staged as CT2N0 and taken up for treatment. The plan was to do a total amputation of penis with a perineal urethrostomy and a DSLNB of the inguinal region. So any considerations before total amputation of penis? whether you should do a DSLNB, SLNB versus SIBD. I think we've done all of these. What technique of dye injection, how to do this. Frozen section, we didn't talk about this for DSLNB. Unlike what I said for a staging inguinal lymphadenectomy is usually to be done, for DSLNB it should never be done. Because for DSLNB, you have to send the node, you have to take sections at 1 mm intervals, you have to look for pericapsular infiltration, so on and so forth. If you give it for frozen section, they are only going to take 2 sections bivalvate, and in the process of freezing them, there might be some loss of tissue. So for a DSLNB, never send for frozen sections. So a total prostatourethrectomy with permanent. So what really happened here was we did all of these, and the frozen section margin from the cut margin of the urethra showed tumor. So what do we do next? Because the cut margin of the urethra showed tumor, we took extra margin. There also it showed that the tumor was going along the cavernosa. So we needed to do a total urethrectomy. So now if you are going to do a total urethrectomy, you have to enter into the pelvis. If in the event that the sentinel nodes come out positive later on, then going and doing a pelvic node dissection again later on after already entering into the pelvis might be a difficult condition again. So we send the dynamic sentinel nodes that we had taken out for frozen section, and lo and behold, both sides came out to be positive. So the on-table plan was we had to convert a total urethrectomy, total amputation of penis with a perineal urethrostomy that we had actually planned. We had to convert that into a total prostatourethrectomy with a permanent SPC with bilateral ilioinguinal block dissection. So this is thanks to one of our PGs who had actually, we are during discussion and everything else had actually taken consent for all of these things, explained everything to the patient. So here is a small example of how your best laid plans can go to waste. The post-op histopathology was squamous cell carcinoma extensively infiltrates the spongiosa cavernosa and the urethra. Margins were negative. Fortunately, the urethral margin at the internal urethral meatus was negative. Multiple nodes positive with PNI, perinodal spread, no LVI, stage PT3N3. So this patient was planned for adjuvant 6 cycles of for TIP chemotherapy. Today it would have been TIP. A few years back it was Taxol carboplatin. That was the adjuvant chemotherapy given. Role for radiation here, like I said, the role for radiation here is minimal. So that is what it is. So I think we can leave it at that. That leaves us about 15 minutes for questioning. Dr. Somashekar, any comments, or should we proceed to the question? Sorry.
Sir, you may proceed with the questions, please.
Okay, so I'm opening up the chat box. Just let me quickly start taking questions one by one. From Dr. Praveen to everyone. Dr. Praveen, if the lesion is T1, like I said, in the current staging system of AJCC, in the previous AJCC classification, urethral involvement was plus. It was either a T2 or a T3. But in the current AJCC classification, urethral involvement is taken away from the T staging. So if it's a T1 or a T2, whatever it is, it remains that stage irrespective of urethral involvement. Dr. Praveen, patient has underwent a partial penectomy with bilateral superficial inguinal lymph node dissection. The histopathology is showing 2 nodes on the left side and 1 node on the right side positive for metastasis. Should we go for bilateral or left PLND? Like I said, so any node positive in one groin, you should go and complete the ipsilateral, superficial and the deep inguinal node dissection. So here both sides are positive, superficial nodes are positive. So both sides you should complete the inguinal block dissection, the superficial and the deep. If you actually look at the NCCN guidelines, only the side that is having 2 nodes, you should do a pelvic node. The side that is having only 1 node, you should ideally not do a pelvic node. But then you've completed the right inguinal node dissection, and then you send it for pathology, and suppose the deep inguinal shows a small focus of tumor, that makes it 2 nodes. So you'll have to come back again and do the iliac node dissection again. So for ease of practicality, most patients that have inguinal block dissections undergo a pelvic node dissection. But your question is right. If it's a textbook, if you're asked this question in the answer in the way that I told you, this is what is the recommendations from NCCN. But for ease of practicality and in the real world, this is what we would end up doing most of the time. From Dr. Praveen, if the inguinal lymph node is inoperable, then we should go for neoadjuvant or operate primarily and then neoadjuvant. Like I said, we should make a distinction between borderline operable, and the reason in borderline operable, like I said, our protocol is to go for resection if possible upfront, and inoperable is inoperable. You cannot operate at all. So there is no question of operating and then go ahead and doing neoadjuvant chemotherapy. So operating the primary, yes, a lot of these patients in inoperable nodes will have large tumors, will have ulcerated tumors. It might be fungating, it might have been discharging a lot of pus, so on and so forth. So if you give chemotherapy there's a high chance of having septic complications. Yes. If it's a dry ulcerated lesion without soakage, without discharge, you might give neoadjuvant chemotherapy without operating on the primary. But in the scenario that I said, large, ulcerated, fungating, purulent, foul-smelling discharge, where if you give chemo, patient might land up in toxicity, it might be wise to operate on the primary and then give treatment for the neoadjuvant or adjuvant therapy. Dr. Sravya, is it necessary to use dual and dye for penile cancer? Always, always, always. It is mandatory. Single dye is insufficient to do it in penile cancer. In fact, I'll go ahead one step and state here that for penile cancer, please do not attempt to do DSLNBs. I mentioned it here in only in the interest of knowledge, but you should not do it until and unless you are in a high volume center and you have standardized your protocol, because even in the best of hands, in the highest volume centers in the world, the false negative rates are very, very high. And we know that if there is a false negative, you miss it and the patient comes back to you later at some point in time with a positive, with a recurrence in the groin, then his survival has really, really dipped. So one, do not attempt it if you are not adequately trained in a high volume center, unlike breast cancers or melanomas which I treat. One. Second, unlike in breast cancers, where a lot of places the single dye has replaced the dual dye is mandatory in penile cancer. A single dye is clearly insufficient. The only change that has happened is in the Netherlands Cancer Institute. They are now trying to see whether instead of the radiocolloid and the blue dye, they can substitute ICG for the blue. So it is radiocolloid with ICG instead of radiocolloid with blue dye. In our own hands, the identification rate is upwards of 99%. So I really don't see a need to go the ICG way. From Dr. Sandeep, ideal margins of resection, any relation to grade? Yes, I am assuming that you are here talking about resection of the primary. I would recommend everybody to go and read up this wonderful paper by Dr. Santosh Menon from the Tata Hospital about how far the tumor spreads in the primary from based on grade. So if it's a grade 1 tumor, you should attempt, a final pathology margin of about 5 mm to 7 mm is adequate. Anything more than that, you need at least a 1 centimeter margin. In a grade 3, it's probably a 2 centimeter margin. Resectable bilateral FNAC proven groin node. Should we consider NACT? Of course, like I said here, we should consider primary surgery for reasons that I already alluded to, and then consider for neoadjuvant therapy, yes or no, based on pathology. Can we consider lab PLND if negative and proceed to upfront surgery? I'm not really sure. I understand your question. For PLND if negative and proceed to pelvic node surgery, you can do ilioinguinal block dissection and you can do a pelvic node dissection for staging the pelvis. How you do it is up to you. This question is by Dr. Bharat. I am not really sure. Maybe if you can expand what you mean by should we consider lap PLND, I can attempt to answer that. I'm sorry, I don't understand the question there. Dr. Sendil, sir, if bilateral inguinal block dissection is done, preserving scrotum leads to scrotal edema. Ha ha ha. You hit the $1 million question. Usually, what we see is that the medial most nodes, if you go and resect, if you in ileoinguinal block dissections, the medial margin, you should always see the cord. Seeing the cord is very, very important. However, in our own experience, a lot of the scrotal edema that develops is when the cord nicely grows. There is an envelope of tissue, there is an envelope of fascia around it. If that fascia is disrupted, is when most of the scrotal edema happens. If you do not disrupt it, try not to disrupt it, maybe you will be saved from scrotal edema. Once the scrotal edema develops, it just develops. There is really no way that you can, unreduce it. You might just have to talk to your plastic surgery colleagues, and then you might have to just remove a lot of scrotal skin and then primary close the scrotum to treat this. This is what we've done in a couple of patients. Although having said that, not a lot of patients are willing for the same. After DSLNB frozen section, like I said, frozen section should never be done if you have done a DSLNB because it destroys tissues, and you cannot take the the every 1 millimeter or 2 millimeter cuts that you need to do in a frozen section to process the nodes properly. Can ICG replace DSLNB? ICG cannot. ICG is a technique of doing DSLNB. In DSLNB, we use conventionally we use isotope with blue dye. ICG is people are trying to see whether the blue dye can be replaced with ICG. So it is radiocolloid plus ICG. That is still a technique of DSLNB, just using a different colored dye, a green dye instead of a blue dye. So I think that answers all of those questions, Dr. Bar. I think there is just one more question. Yeah, Dr. Bharat, I think I answered the first part of your question. When deciding between NACT and upfront surgery for resectable FNAC proven, is there a role to do a PLND and frozen section? There is really, if it's an operable node, it's an operable node. You go, when I'm talking about operable node, I mean both the inguinal and the pelvic should be operable. So if you operate on both, then you can go ahead and give adjuvant chemotherapy. If it's an inoperable node, if it's a PLND is positive, would we consider NACT? Not really. If it's an operable node, both either inguinal or pelvis, we finish the surgery for both the pelvis and the groin and then give for chemotherapy. Not necessarily a pelvic node positive, we will give chemotherapy and then take up for surgery. Approach to ileoinguinal block dissection. Incision, separate abdominal, inguinal, or through the same inguinal incisions. Any differences? So, multiple inguinal techniques are there. You can give 2 parallel incisions. You can give a lazy S incision. You can do any number of things. We are very comfortable giving a lazy S incision and completing the inguinal lymphadenectomy. We try to do the pelvic lymphadenectomy by lap. We try to do the pelvic lymphadenectomy by lap, and then we try to do if not lap is not available, you can make an incision into the external oblique aponeurosis, extraperitoneally enter into the pelvis and stays the groin from there. So you can use the same incision for pelvic and inguinal nodes. Sir, if not FS after DSLN, please elaborate on how to proceed intra once again. I already showed it. If the FNAC, if the DSLNB is positive, then you made the skin incision and then you've done some digging around for the SLNB and you've taken the node out. If there are extracapsular infiltration, that entire cavity is contaminated. So you have to widely resect the skin, and that entire cavity that had the DSLNB is potentially now contaminated. So that entire cavity should be removed en bloc along with the specimen, and then you either close primarily or flap depending on how much digging around you've done and how much of the skin and cavity you've resected. So does that complete all our questions? I hope I have not missed anything.
Sir, there are a few in the Q&A section as well.
Q&A section.
Extreme right, there are 3 dots.
Yeah, 3 dots. Yeah, Q&A section. Yeah. 1 minute. I'll go up. Yeah, so I think Dr. Manish Jathani and Dr. Muthuraman have asked why is it that it is called DSLNB in CA penis as dynamic word is not used in AGI as a subsite. I think this is a wonderful question, and this is a question that I'm very happy to take. However, this is a very interesting question and makes for excellent reading. So all questions are not answered at the end of a session. There should be some homework that you should go and look forward to. I think this is homework for you. And if you are not able to answer it, please DM me, and I'm more than happy to answer this for you. But if you read it, it makes for excellent reading, and it's a very, very interesting reading. So this is homework for you. Thanks to Manish and Dr. Muthuraman for bringing this out, which gives you a little bit of homework. Sir, whether ICG will replace lymphoscintigraphy in future? Like I said, anything that we do has to be evidence-based. The trials as of date from NCI Netherlands is trying to replace the blue dye with the lymphoscintigraphy and not the lymphoscintigraphy. Sorry, it's trying to replace the blue dye with ICG, not the lymphoscintigraphy with ICG. In the future, we really don't know. We'll have to wait and watch. The techniques to prevent or reduce the skin flap morbidity by doing groin dissection. Use knife if you can. If you are using diathermy, do not place your incisions, multiple times. Just one shot and you should be done with that. Never return to the same area. And you carefully plan your flap. The flap should be such that the superficial fascia is part of the flap, and you keep sticking to the to the fascia. People have this small habit of looking at how thick it is, looking at the fat, looking at the thickness. Don't ever do that. Just look at the superficial fascia, and the superficial fascia should be part of the flap. And if you keep following the fascia, you will usually be very, very safe. Horizontal inguinal crease incision versus I mean, there is really no better incision. I use a lazy incision. I am very comfortable with it. Horizontal or vertical, I mean, I have very little experience with this. Whatever rocks your boat, whichever you are good at, and if you can do that without morbidity, I think that should be fine. Sir, which stage onwards should we go for MRI in primary in penis? Is palpation enough in some cases? I think palpation is enough in most cases. We only go ahead and do an MRI if there are equifocal findings like in the case capsule that I showed to you, or if we feel that the scrotum is infiltrated, or if we feel that if the crura or the bulbospongiosis or the ischiocavernosus or if any musculature is involved, that is when we go ahead and do an MRI. Otherwise, for most instances, an MRI should be more than sufficient. I think that completes all the questions in the Q&A and the chat.
Excellent, sir. So thank you very much, Professor Dr. Anand, for the presentation, and thank you very much, trainees, for joining the session.
I think we are finishing back dot at 8:30 also.
Yes, sir. Thank you.
So if that's all right, can we close this session, or how do we do this?
Yes, sir. Thank you very much for your time.
Okay, thank you so much. Thanks everyone. Thank you.